Bismillah Rahmanir Rahim. Assalamu alaikum. Today we will be discussing about lymphatic filariasis. By the end of this session, all of you should know about the following. You can go through all these things. What is lymphatic filariasis, history, epidemiology, morphology of the causative organisms, mode of transmission, life cycle, pathogenesis, signs and symptoms, laboratory diagnosis, treatment, and prevention and control. Lymphatic filariasis is a parasitic disease that can result in an altered lymphatic system and the abnormal enlargement of the body parts, causing pain, severe disability, and social stigma. The WHO has identified lymphatic filariasis as the second leading cause of permanent and long term disability after leprosy. And filariasis is the pathological condition caused by infection of filarial nematodes transmitted by different vectors. There are three types of filariasis, and the important from our point of view is Wuchereria bancrofti, which causes diseases in 90% of the individuals. You can see this picture over here as well. And as far as this lymphatic filariasis is concerned, it is transmitted with the bite of infected mosquito, which is responsible for considerable suffering, deformity, and disability. Infection occurs in blood vessels, lymphatic system, connective tissues, and serous cavities of human beings, and all the parasites have similar life cycle in human beings. Adults are seen in lymphatic vessels. Offsprings are seen in peripheral blood during night. Lymphatic filariasis is thought to have affected humans for the last 4,000 years, and artifacts from ancient Egypt around 2000 BC are there, which can be seen. And then also from the Nok civilization in West Africa shows possible elephantiasis symptoms. The symptoms of bancrofti filariasis had been mentioned as elephantiasis, erbicum in the ancient literature, and later on in 1866, 1872, 1878, it was demonstrated that the Culex mosquitoes are the intermediate host, and also described the nocturnal periodicity of microfilariae in the peripheral blood. As far as the epidemiology is concerned, elephantiasis caused by lymphatic filariasis is one of the most common causes of disability in the world, and it is considered endemic in tropical and subtropical regions of Africa, Asia, Central and South America, and Pacific Island nations. As many as 10% of women can be afflicted with swollen limbs, and 50% of men can suffer from mutilating genital symptoms. Filariasis is considered endemic in 73 countries. 37 of these are in Africa. And a report in 2012 noted that lymphatic filariasis affected 120 million people, and 1 billion people are at risk for infection. About 40 million people were disfigured or incapacitated by the disease in 2015. The bancrofti occurs in sub-Saharan Africa, Southeast Asia, the Indian subcontinent, many of the Pacific Islands, and focal areas of Latin America and the Caribbean. And the vectors of lymphatic filariasis, a little bit about that. The major vectors of W. bancrofti are the mosquitoes of the genus Culex. And then Anopheles, Culex mainly spreads this disease in urban and semi-urban areas, and then the Anopheles in rural areas of Africa and elsewhere. And then the Aedes also transmits this disease in islands of the Pacific. You can see the morphology of all the three forms of the Vechureria bancrofti and the other two forms as well. The first stage of the first stage is the larva is called microfilaria, and microfilaria are found in the peripheral blood, hydrocele fluid, and in the urine as well. It has a hyaline sheet and cuticle lined by subcuticulous cells. Then somatic cells or nuclei are also present. The Vechureria bancrofti, the adult worm is long, thread-like, minute, whitish, transparent nematode, and the interior end is surrounded by two rows of 10 sensile papillae. Posterior end contains anus at the terminal end. The male measures around 2.5 to 4 centimeter in length by 0.5 mm in thickness, and the female measures 8 to 10 centimeter in length and 0.3 mm in thickness. As far as the mode of transmission is concerned, the infection occurs when filarial parasites are transmitted to humans through mosquitoes. We've already discussed what are the different forms of mosquitoes which spread this disease in different parts of the world. The lymphatic filariasis is transmitted by the bite of infected mosquito which harbors the larva. And in the pre patent period, it is not known, it hasn't been diagnosed as such to see this, but the clinical incubation period is 8 to 16 months. And lymphatic filariasis is transmitted by different types of mosquitoes. For example, we've already discussed all of this. Then this is, you can go through this picture. It is a very elaborate diagram which shows the life cycle of Vechureria bancrofti, which causes filariasis. You can see the different stages starting from stage 1, 2, 3, 4, 5, 6, 7, and 8. And its life cycle is in two hosts, the man and the mosquito. And as I've already mentioned, that the different types of mosquitoes which transmit the disease include the Culex, Anopheles, as well as Aedes. And the mode of transmission is by bite of infected female mosquito. And the infective form is the third stage of larva. Normally, what happens is that the sheathed microfilaria ingested by the mosquito during its blood meal loses its sheath within the first 1 to 2 hours, and then it migrates to the thoracic muscles of the mosquito. And the first stage of larva is within the next 48 hours, in which it becomes thick, short, sausage shaped forms with short, spicy tail. Then within 3 to 7 days, it mounts once or twice in 3 to 7 days' time. And in the second larval stage, the larger sausage shaped larva appears. And then there is the third stage in its life cycle, which is which ranges from 10th to 11th day after a person has been bitten by a mosquito carrying this infection, and this is the infective stage. when it enters the proboscis of the mosquito on the 14th day, and development in mosquito is completed within 10 to 20 days. Then once when this enters into the human beings, the mosquito with which bites a man, it releases the third stage larva. It at times also deposits on the skin, and these then reach the lymphatic channels and migrate to the inguinal lymph nodes, develop into adult worm which is sexually mature. And this adult male and female worms are coiled up in the regional lymphatics and lymph nodes. And then fertilization takes place over there, and the gravid female gives birth to microfilaria. And these reach the thoracic and lymphatic duct and venous system and peripheral blood. And this is how it causes the complications. As far as the pathogenesis is concerned, the entrance of the infective larva into the human host, we've already discussed it, but just to refresh it, that the infective larva enter into the human host, and the presentation of clinical systems or observable signs is variable and can be as short as 4 weeks or as long as 8 to 16 months. And the pathogenic effects seen in Vechureria bancrofti are produced by the adult worm, which could either be living or dead. And this is the L3 larva, and the microfilaria uh, are not pathogenic as such. And the falling stages occur subsequently in the pathogenesis of lymphatic filariasis. What happens is that there is dilatation of lymphatic vessels, infection of the lymphatics, which is called lymphangitis, then obstruction of the lymph nodes. And when lymphangitis takes place, there is mechanical irritation caused by the movement of adult worms inside the lymphatic system. And there is liberation of toxic metabolites by the growing larva and secretion of some toxic fluid by fertilized females, which causes allergic manifestations like urticaria, fugitive swelling, and lymphedema. Uh, so the signs and symptoms start appearing, and the majority of the infections show no external signs of infection as such, but they still cause damage to the lymphatic system and the kidneys, as well as alter the body's immune system. And then when lymphatic filariasis develops into chronic conditions, it leads to lymphedema, which is tissue swelling, or elephantiasis, skin tissue thickening of limbs, and hydrocele, which is the scrotal swelling. And then absorption of toxic products liberated from the dead worms undergoing disintegration, it causes allergic manifestations. And then secondary invaders could be that bacterial infection can also take place. One of the important thing which you can see in this picture is that lymphatic obstruction takes place, and the mechanical blocking of the lumen by dead worms, which act as an ambulus. This obliterates, and there is endolymphangitis, endothelial proliferation, and inflammatory thickening of the walls of the lymphatic vessels. There is excessive fibrosis of the lymphatic vessels caused by recurrent and repeated attacks of lymphangitis. There is fibrosis of the afferent lymph nodes draining the particular area, and effects of lymphatic obstruction. It is two types of conditions are produced. One is the lymph varix, varicosity of the lymphatic vessels, and then elephantiasis, hypertrophy of the affected part, which you can see in this picture. Then other clinical manifestations in the acute disease could be that there could be fever and chills and rigors, then lymphedema and pain, lymphadenopathy, which could be generalized lymphadenopathy like cervical, axillary, inguinal, and generalized. Then acute filarial lymphangitis or acute derma tall lymphangiodenitis, is a condition which could be seen. There could be hematuria, there could be inflammatory granuloma or abscesses, pain in the testes, and there could be epididymoorchitis. And when it turns chronic, there could be epididymoorchitis, hydrocele, lymph varices, and elephantiasis. There could be breast edema, and in further clinical manifestations could be that when the stage of oculate filariasis reaches, there is a condition in which there is massive eosinophilia, 30 to 80%, and absolute eosinophilia count more than 3,000 per millimeter cube. There could be generalized lymphadenopathy, hepatosplenomegaly, pulmonary symptoms could appear. There could be adult worm produces microfilaria continuously, but they do not reach the peripheral blood because they are destroyed in the tissues. So this is diagnosis is very important, and the standard method for diagnosing active infection is by finding the microfilaria via the microscopic examination. Different methods of examination are used, like blood microscopy, then the DEC provocation test, the quantitative Buffy coat examination, urine microscopy, microscopy of the hydrocele fluid and lymph node aspirate. Then, and normally in blood microscopy, 2 to 3 drops of peripheral blood are collected by finger prick, and the blood is normally collected at during the nocturnal period, that is from 10 p.m. to 4 a.m. In the night. And it could also be, the sample could also be taken in the sub-periodic nocturnal period between 8 p.m. to 4 a.m. during night, and also between 2 p.m. to 6 p.m. in the afternoon, because these are the times when you can see these microfilariae in the blood. Then, if we go further with microscopy, we can do urine microscopy. Microfilaria demonstrated in the urine. Usually 10 to 20 ml of early morning sample is collected, centrifuge, and sediment is examined under the microscope for microfilaria. Then microscopy of hydrocele fluid or lymph node aspirate is also done, and this aspirate is dissolved in ether or chloroform or xylol, and the fat globules and used to dissolve. Basically, why these are used is to dissolve the fat globules, and the same method is also at times employed in urine examination. And then we can also do immunodiagnosis through serological tests or and cellular assays. Then antigen or antibody detection is also done. In the antibody detection assays, it could be done through different laboratory methods. One of the most prominent ones are the ELISA and the chemiluminescence immunoassay, in which light reaction takes place, and the equipment is designed this way that it identifies the light which is emitted and identifies the antibodies. Then filarial skin tests could be done. It is an immediate hypersensitivity test in which filarial antigen is injected on skin. After 30 minutes, a wheal over 2 centimeter appears. Then in vitro lymphocyte responses to filarial antigens could also be done. And then molecular methods, PCR, you've heard about that. PCR, it has been deployed, which can detect as low as 1 picograms of filarial DNA. So these are the different kind of diagnostic tests which could be performed. Talking about the treatment, normally what is considered is mass drug administration is done, and the medicines which are used is albendazole 400 milligram alone twice per year for areas which are co-endemic with loiasis as well. Then ivermectin Mectin 200 micrograms per kilogram with albendazole 400 milligram in countries with onchocerciasis, and then diethyl carbamazine citrate is also used along with albendazole in countries without onchocerciasis. And recent evidence indicates that the combination of all three medicines can safely clear almost all microfilariae from the blood of infected people within a few weeks, as opposed to years, using the routine two medicine combination. So it is recommended to use the three drugs combination if we want effective treatment of the patient. Lastly, I would like to discuss about the prevention, because the WHO, through its program related to tropical these diseases, they are now working on eradication of lymphatic filariasis, and the World Health Organization recommends mass deworming, treating entire groups of people who are at risk with a single annual dose of two medicines, namely albendazole in combination with either mectin or diethyl carbamazine citrate. Then in prevention and control, there are other methods which are also used, and these depend upon mosquito control, chemotherapeutic control. In mosquito control, clinical control is done by spraying insecticides, and then biological control by the use of carnivorous bacteria and carnivorous fish, and then spore forming bacterium. Then environmental control can be considered by efficient drainage and sewage system to eliminate the mosquito breeding places. Then reduction of non-vector contacts by use of mosquito nets and house screen. Then we can use the chemotherapeutic control. I've already mentioned that. And it is based on the mass or selective treatment of the cases by administering these medicated salts in the populations exposed to filarial infections. The efforts of the global program to eliminate lymphatic filariasis are estimated to have prevented 6.6 million new filariasis cases from developing in children between 2000 2007, and to have stopped the progression of the disease in another 9.5 million people who had already contracted it. And the goal is of elimination by 2020. So we've yet got to see if that goal is achieved or not. But vector control is the most important control, and mosquito control is a supplemental strategy supported by the World Health Organization. It is used to reduce transmission of lymphatic filariasis and other mosquito-borne infections. With this, I end today's lecture. I thank you, but just to repeat a few of the key facts are that lymphatic filariasis impairs the lymphatic system and can lead to the abnormal enlargement of the body parts, causing pain, severe disability, and social stigma. Around 900 million, 893 million to 900 million people in 49 countries worldwide remain threatened by lymphatic filariasis and require preventive chemotherapy to stop the spread of this parasitic infection. In the year 2000, over 120 million people were infected, with about 40 million disfigured and incapacitated by the disease. And lymphatic filariasis can be eliminated by stopping the spread of infection through preventive chemotherapy with safe medicine combinations repeated annually. There are more than 7.7 billion treatments have been delivered to stop the spread of this infection since the year 2000. And 597 million people no longer require preventive chemotherapy due to successful implementation of the World Health Organization strategies. And lastly, a basic recommended package of care can alleviate suffering and prevent further disability among the people living with the disease caused by lymphatic filariasis. Thank you very much.